Continued. Immunity and inflammation. Readings. 1. Giddens 22 and 23. Van Meter and Hubert, 2023, Chapter 5 and 7-3. Lewis 2023, Chapter 141,617 1867-4. Pharmacology Notes Unit F. Fundamentals of Nursing Pharmacology 1. Antimicrobials 2. Autonomic Nervous System Regulation. Topics 1, 2, 3. Allergies and hypersensitivity disorders. Infectious disease, HIV/AIDS, cancer and immune system, role of surveillance, tumor-associated inflammation. Allergies and hypersensitivity, diagnostic tests, primary testing, NC red blood cell count and white blood cell count with differential, fluorescent anti-nuclear antibody, NC reactive protein CRP, erythrocyte sedimentation rate ESR, allergy testing, genetic testing, rheumatoid factors RFS, Western blot test, torch antibody panel, organ function tests. 5. Clinical management, primary prevention, immunizations, avoiding high-risk behaviors, adequate nutrition, exercise, infection control measures. 6. Clinical management, secondary prevention, screening. No routine screenings for general population. Human immunodeficiency virus HIV screening for those with specific risk factors. 7. Interrelated concepts. Inflammatio. N. Infection, tissue integrity, stress. Glucose, nutrition, fatigue regulation. 8. Infectious disease, HIV/AIDS, transmission of HIV, fragile virus transmitted only through contact with body fluids, modes of transmission, blood, semen, vaginal secretions, and breast, milk, sex with an infected partner, exposure to infected blood or blood products, prenatally at the time of delivery or breastfeeding. Pathophysiology. HIV is an RNA virus, retrovirus, unable to replicate unless inside a living cell, binds to specific CD4 receptor sites, and CCR5 and CXCR4 co-receptors on the cell's surface. Reverse transcriptase assists to make viral DNA. Viral DNA enters the cell nucleus and splices itself into the genome permanently. Integrase, consequence of integration into genetic structure. All daughter cells from the affected cell will be infected. Viral DNA will direct cell to make HIV, viral load in the blood. Initial infection, viremia, large viral levels in blood for 2 to 3 weeks. Transmission is more likely when viral load is high, followed by prolonged period, years of low viral load. Cells with CD4 receptor sites are infected. CD4 plus T cells at helper cells, lymphocytes, monocytes, macrophages, astrocytes, oligodendrocytes. Immune dysfunction in HIV disease is caused predominantly by damage to and destruction of CD4 plus T cells. These cells are targeted because they have more CD4 receptors on their surfaces than other CD4 receptor-bearing cells. Adults normally have 800 to 1/200 CD4 plus T cells per microliter (mcl) of blood. The normal lifespan of a CD4 plus T cell is about 100 days, but HIV-infected CD4 plus T cells will die after an average of only 2 days. HIV destroys about 1 billion CD4 plus T cells every day. Viral load in the blood, normal range is 800 to 1/200 cells mcl. Immune problems start when CD4 plus T cell counts drop to below 500 cells mcl, allows for opportunistic diseases. Severe problems begin to develop below 200 CD4 plus T cells mcl. Opportunistic diseases are the main cause of disease, disability, and death in HIV infection. Pig, 17.1 viral load in the blood, and CD4 plus T cell counts across the spectrum of untreated. Human immunodeficiency virus HIV infection. AIDS, acquired immune deficiency syndrome. Fig, 17.4 timeline for the spectrum of untreated human immunodeficiency virus HIV infection. The timeline represents the course of the illness from the time of infection to the clinical manifestations of disease. AIDS, acquired immune deficiency syndrome. Clinical manifestations and complications: acute infection, and flu-like symptoms, fever, swollen lymph glands, sore throat, headache, malaise, nausea, muscle and joint pain, diarrhea, or a diffuse rash. These symptoms are called acute retroviral syndrome and occur about 1 to 3 weeks after infection and lasts for 1 to 2 weeks. Early chronic infection, generally asymptomatic, when fatigue, headache, low-grade fever, night sweats, and persistent generalized lymphadenopathy often occur. But most patients are not aware of infected status. The median interval between untreated HIV infection and a diagnosis of AIDS is about 10 years. During this time, CD4 plus T cell counts remain above 500 cells, normal or slightly decreased, and the viral load in the blood will be low. This phase has been referred to as asymptomatic disease. But during this time, infected people continue their usual activities, which may include high-risk sexual and substance-using behaviors. This is a public health problem. Intermediate chronic MCD4 plus T cells drop to 200 to 500 cells, MCL. MCL, viral load increases. HIV advances to a more active state. And symptoms seen in earlier phases tend to become worse, causing persistent fever, frequent drenching night sweats, chronic diarrhea, recurrent headaches, and fatigue severe enough to interrupt normal routines. Other problems may include localized infections, lymphadenopathy, and nervous system manifestations, oropharyngeal candidiasis, thrush, shingles, oral hairy leukoplakia, persistent vaginal candida infections, herpes, bacterial infections, Kaposi sarcoma KS, late chronic or AIDS, clinical manifestatio, NS and complication S continued, immune system severely compromised, great risk for opportunistic disease, possible malignancies, wasting, and dementia. Opportunistic diseases may occur at the same time, further compounding the difficulties of diagnosis and treatment. Rapid HIV antibody tests, diagnostic studies, 2 types in Canada: point-of-care test and the self-test, provide results in minutes. Rapid testing is highly reliable and provides immediate feedback to patients who can then be counseled about treatment and prevention. This is an important advantage because many people do not return to get their test results when other testing methods take longer to obtain. The results are used. Most useful screening tests detect high V-specific antibodies. Table 17.13. Medication therapy mechanisms of action of medications used to treat HIV infection. Medication classification: non-nucleoside reverse transcriptase inhibitors, nucleoside reverse transcriptase inhibitors, nucleotide reverse transcriptase inhibitors, protease inhibitors. Mechanism of action: combine with reverse transcriptase enzyme to block the process needed to convert HIV RNA into HIV DNA. Insert a bit of protein, a nucleoside, into the developing HIV DNA chain, blocking further development of the chain and leaving the production of the new strand of HIV DNA incomplete. Inhibit the action of reverse transcriptase. Integrase inhibitors, fusion inhibitors, entry inhibitors, prevent the protease enzyme from cutting HIV proteins into the proper lengths needed to allow viable virions to assemble and bud out from the cell membrane. Prevent viral DNA integration into the CD4 per cell chromosome. Prevent binding of HIV to cells, thus preventing entry of HIV into healthy cells. HIV, human immunodeficiency virus, RNA, ribonucleic acid. Cancer and immune system, role of surveillance, tumor-associated. Inflammation, risk factors, age, rationale, as individuals age, cumulative exposure to carcinogens, environmental factors, and DNA replication errors increases. Cellular repair mechanisms and immune surveillance become less effective, allowing for the accumulation of genetic mutations that can lead to cancer. Genetic predisposition. Rationale: mutations in tumor suppressor genes, for example, BRCA1, BRCA2, in breast and ovarian cancer, or oncogenes can be inherited. These mutations disrupt normal cell cycle control, DNA repair, and apoptosis, increasing the risk of malignancies. Tobacco use. Rationale: tobacco contains carcinogens like polycyclic aromatic hydrocarbons and nitrosamines. These substances cause DNA damage, induce mutations, and promote chronic inflammation, creating a favorable environment for tumorigenesis. Diet and obesity. Rationale: high-fat, low-fiber diets and obesity contribute to chronic inflammation, insulin resistance, and increased levels of growth factors, for example, insulin-like growth factor 1. Excess adipose tissue also produces estrogen, which is linked to hormone-sensitive cancers such as breast and endometrial cancer. Physical inactivity. Rationale: a sedentary lifestyle promotes obesity, alters metabolic homeostasis, and reduces immune function. Lack of physical activity is associated with increased inflammation and reduced ability to clear potentially malignant cells. Chronic inflammation. Rationale: conditions like inflammatory bowel disease or chronic hepatitis create a pro-inflammatory environment that produces reactive oxygen species, ROS. ROS cause DNA damage, leading to mutations and potential malignant transformation. Viral and bacterial infections. Rationale: viruses such as human papillomavirus, HPV, and hepatitis B/C integrate into host DNA, disrupting regulatory genes and promoting carcinogenesis. Helicobacter pylori infection induces chronic gastritis, leading to gastric adenocarcinoma. Radiation exposure. Rationale: ionizing radiation, for example, from X-rays or radon, damages DNA by causing double-strand breaks. If repair mechanisms fail, mutations accumulate. Ultraviolet UV radiation from sunlight induces pyrimidine dimer formation, leading to skin cancers like melanoma. Environmental and occupational exposures. Rationale: exposure to carcinogens such as asbestos, benzene, and pesticides damages DNA directly or through oxidative stress, increasing cancer risk. For example, asbestos fibers can cause chronic inflammation in lung tissue, leading to mesothelioma. Hormonal factors. Rationale: prolonged exposure to estrogen and/or progesterone, for example, from early menarche, late menopause, or hormone replacement therapy, stimulates proliferation of hormone-sensitive tissues, increasing the risk of cancers such as breast and endometrial cancer. Alcohol consumption. Rationale: alcohol is metabolized into acetaldehyde, a toxic compound that damages DNA and impairs its repair. Alcohol also promotes liver inflammation, increasing the risk of hepatocellular carcinoma. Immunosuppression. Rationale: immunocompromised states, for example, HIV, AIDS, or post-transplant immunosuppressive therapy, impair the immune system's ability to detect and destroy malignant cells, allowing tumors to grow unchecked. Occupational carcinogens. Rationale: long-term exposure to specific chemicals such as arsenic or formaldehyde leads to chronic irritation, inflammation, or direct genotoxic effects, promoting cellular changes that lead to cancer. Personal or family history of cancer. Rationale: a history of cancer in an individual or family suggests genetic mutations, shared environmental exposures, or inherited syndromes, for example, Lynch syndrome, that predispose to cancer. Pathophysiology overview. The pathophysiology of cancer involves a series of genetic mutations and epigenetic changes that lead to uncontrolled proliferation, evasion of regulatory mechanisms, angiogenesis, and metastasis. This multi-step process allows cancer to grow, invade, and adapt, making it challenging to treat. Understanding these mechanisms provides the foundation for developing targeted therapies and interventions. Pathophysiology. Initiation, genetic and epigenetic changes, promotion, clonal expansion, progression, malignant transformation, immune evasion, hallmarks of cancer tumor microenvironment, metastasis, energy metabolism, benign, malignant, grow slowly, grow rapidly, well-defined capsule, not encapsulated, benign versus malignant, tumors, not invasive, well-differentiated, low mitotic index, invasive. Poorly differentiated high mitotic index do not metastasize, can spread distantly, metastasis, named according to the tissues from which they arise, and include the suffix -oma benign tumors. Lipoma, leiomyoma, meningioma, may progress to cancer, carcinoma, malignant. Tumors named according to the tissues from which they arise. Epithelial tissue, adenocarcinoma, from ductal or glandular tissue. Sarcoma, mesenchymal tissue lymphoma, lymphatic tissue, leukemia, blood-forming cells, carcinoma in situ cis. Pre-invasive epithelial malignant tumors of glandular or epithelial origin that have not broken through the basement membrane or invaded the surrounding stroma. Which statement is true? A. All neoplasms are cancerous. Benign growths are cancerous. B. Malignant tumors have slow growth. C. Cancer refers to a malignant tumor. D. Cancer is predominantly a disease of aging. Cancer cells biology. Multiple mutations are required before cancer can develop. Clonal proliferation or expansion. As a result of a mutation, a cell acquires characteristics that allow it to have selective advantage over its neighbors. Increased growth rate or decreased apoptosis. Transformation of normal cells. Decreased need for growth factors to multiply. Lack contact inhibition. Anchorage independence. Immortality, inflammation, and cancer. Chronic inflammation is an important factor in the development of cancer. Cytokine release from inflammatory cells, Helicobacter pylori, chronic inflammation associated with peptic ulcer disease, stomach carcinoma, mucosa-associated lymphoid tissue lymphomas, tumor-associated macrophage, TAM, key cells that promote tumor survival. Presence frequently correlates with a worse prognosis. Mimic M2 phenotype. Have diminished cytotoxic response, develop the capacity to block T cytotoxic cell and NK cell functions, and produce cytokines that are advantageous for tumor growth and spread. Immune system and cancer. Normal immune system protects against cancer. Immunosuppression fosters cancer. Non-Hodgkin's lymphoma 10x, Kaposi sarcoma 1000x, release of immunosuppressive factors into the tumor microenvironment increases resistance of the tumor to chemotherapy and radiotherapy. Viruses and cancer implicated. Hepatitis B and C viruses. Epstein-Barr virus EBV. Kaposi sarcoma herpes virus KSHV. Human papillomavirus HPV. Human T-cell lymphotropic virus type 1 HTLV1. TNM. The most widely used method to classify the extent and progression of cancer. It provides a standardized way to describe the anatomical spread of tumors, guiding prognosis and treatment planning. Uniform. The TNM system provides a common language for healthcare providers to communicate about a patient's cancer stage. Treatment planning. The stage helps determine the appropriate treatment approach, such as surgery, radiation, chemotherapy, or a combination of modalities. Prognosis. Higher TNM stages generally indicate a worse prognosis due to larger tumors, greater nodal involvement, or metastasis. Clinical trials ensures consistency in selecting patients for trials and evaluating treatment efficacy. Each component represents a key aspect of tumor. Behavior, T tumor size and extent N, nodal involvement M, metastasis. T, tumor size and extent, describes the size and local extent of the primary. TX, primary tumor cannot be assessed. T0, no evidence of a primary tumor. TIS, carcinoma in situ confined to its site of origin without invasion. T1, T4, increasing tumor size or local extension into nearby tissues. The specific criteria for T stages depend on the cancer type. For example, a T2 breast tumor may differ in size from a T2 lung tumor. Tumor. N, nodal involvement, indicates whether NX regional lymph nodes cannot be regional assessed. N0, no regional lymph node lymph involvement. Nodes are NN1 and 3, increasing degrees of lymph. node involvement, including the number affected and of affected nodes and their size. To what, and for some cancers, distant lymph node. Involvement may also be considered. Extent, M, metastasis, reflects whether MX presence of distant metastasis cancer cannot be assessed. Spread to M0, no evidence of distant metastasis. M1, distant metastasis is present. Distant organs indicating advanced disease or tissues. Stage grouping. Stage 0, in situ cancers with no invasion. Stage I2, localized tumors with limited nodal involvement. Stage 3, regional spread with extensive lymph node involvement but no distant metastasis. Stage 4, presence of distant metastasis, indicating advanced disease. Example of TNM staging, breast cancer. T3N2M0, T1N0M0. A large primary tumor 5 centimeters with involvement of 4 to 9. Regional lymph nodes but no distant. Metastasis. A small tumor, less than or equal to 2 cm, no lymph node involvement, and no distant metastasis, representing an early stage cancer. A patient has been diagnosed with prostate cancer that has metastasized to the bone. What stage of cancer does this represent? A, 1B, 2C, 3D, 4. Pain. Little or no pain is associated with early stages of malignancy, influenced by fear, anxiety, sleep loss, fatigue, and overall physical deterioration. To mechanisms, patient pressure, to obstruction, its invasion of sensitive structures, stretching of visceral surfaces, tissue destruction, inflammation, infection, clinical, manifestations, fatigue, most, frequently reported symptom, subjective clinical manifestation, tiredness, weakness, lack of energy, exhaustion, lethargy, inability to concentrate, depression, sleepiness, boredom, and lack of. Motivation syndrome of cachexia, the most severe form of malnutrition, includes anorexia, early satiety, weight loss, anemia, asthenia, taste alterations, and altered protein, lipid, and carbohydrate metabolism anemia, and decrease of hemoglobin in the blood. Mechanisms: Sanchechi, chronic bleeding resulting in iron deficiency, severe malnutrition, medical therapies, malignancy in blood-forming organs, leukopenia and thrombocytopenia. Direct tumor invasion to the bone marrow causes leukopenia and thrombocytopenia. And chemotherapy medications are toxic to the bone marrow. Infection. Infection risk increases when the absolute neutrophil and lymphocyte counts fall. Gastrointestinal manifestations. Dural ulcers caused by decreased cell turnover from chemotherapy and radiation. Malabsorption. Diarrhea. Therapy-induced nausea. Hair and skin manifestations. Alopecia from chemotherapy, usually temporary. Skin breakdown and dryness. Tumor markers. Tumor cell markers, biological markers, are substances produced by cancer cells that are found on or in tumor. Cells in the blood, CSF, or urine. Hormones, enzymes, genes. Antigens, antibodies. Screen and identify individuals at high risk for cancer. Tumor markers are used to diagnose specific types of tumors, observe clinical course of cancer. Problem: false positives and negatives. Histology in tumors are classified based on immunohistochemical analysis of protein expression for improved. Treatment: supplemented by a more extensive genetic analysis of the tumors, enhanced molecular characterization subdivides cancers into therapeutically and prognostically relevant smaller groups. Breast cancer surgery to prevent cancer, colon polyps, biopsy for diagnosis and staging, lymph node sampling, palliative surgery. Cancer treatment, radiation goals: eradicate cancer without excessive toxicity, avoid damage to normal structures. Ionizing radiation damages the cancer cell's DNA. Chemotherapy takes advantage of specific vulnerabilities in target cancer cells, usually given in combinations designed to attack a cancer from many different weaknesses at the same time. Induction chemotherapy. Shrinkage or disappearance of tumors. Chemotherapy Y. Adjuvant chemotherapy. Eliminate micrometastases after surgery. Neoadjuvant therapy. Given before localized treatment to shrink tumor. Vaccines against oncogenic viruses provide protection and prevent the onset of viral-induced tumors. Immunother, APY. Numerous potential therapeutic vaccines have been tested with little success. Allogeneic cancer cell vaccines continue to be tested. Targeted disruption used in combination with chemotherapy. Cancer highly specific. Treatment, inactivate oncogenes. Block angiogenesis. Affect cell metabolism. Induce apoptosis. Neutralize cytokines, chemokines. Topics: chronic inflammatory disease, IBD, colitis and Crohn's, psoriasis and psoriatic arthritis. Next week, Synchronew S, pharmacology, anti-inflammatories, immunosuppressive, immunomodulators, allergy and anaphylaxis, vaccines and immunizations,